So we have Dr. Sonam. She is associate professor at PGI again, who specializes in cornea, cataract, and refractive surgery. Does a lot of work in pediatric cornea. She has a keen interest in ocular imaging and pediatric cornea. Published a lot of articles, and she's also the editor of the Chandigarh Ophthalmologic Society, and also has a keen interest in various you can say imaging and newer techniques which come up, and tries to present it at places where probably and trying to win whatever she can. So that's the passion should be. I mean, very passionate clinician, no doubt. Dr. Sonam, your presentation.
Thank you, sir, for the kind introduction, and I'm really grateful to you for giving me this opportunity. And I'm happy to see Professor Ken here in the audience and other audience as well, because again, as Dr. Sabreen mentioned, we are going to learn a lot from the audience. And as Dr. Maria pointed out, that compared to every other specialty, cornea is less explored when it comes to genetic and phenotyping. So I have few cases to discuss. So coming to the first case, here is this 1-year-old girl who presented with bilateral corneal opacity present since birth, and she had global developmental delay along with a short stature. Here we can see the photo of her face. There's this telecantthus is there, there's bilateral ptosis, broad nasal bridge, and philtrum is absent, and there's abnormal facies. Along with that, she had this epiphyseal, premature epiphyseal short, fusion, and ocular examination shows a low IOP and thick corneas, and axillary length for change was fine in this case. On doing an AIOS2025 and UBM, here we can see that there's presence of this slightly thickened cornea, but there is iridocorneal lenticular adhesions in both eyes with the typical notch in the left eye we can see at the endothelial stromal side. And again, once we look at the phenotype of the ocular phenotype, then along with the systemic features, we thought of the Peters plus like everything, and referred her to the genetics department for further evaluation, where they did find some skeletal abnormalities in this patient. Along with that, there was this COL2A1 gene mutation. Again, it was variant of unknown significance, which is many of the majority of the case are like VUS actually. But in our case, again, the ocular phenotype was suggestive of type 2 Peters anomaly, while the systemic or the genetics evaluation showed something else. And moving on, because I'm going to compile the 3 cases together. Another child who again had systemic and abnormal facies with secondary history of secondary consanguinity, hypertelorism. We can see the epicanthal folds very prominent, long philtrum, depressed nasal bridge, brachydactyly. You can see the short stubby fingers, edema all over the limbs, and large genitalia, cafe ulae spots all over the back. And coming to the ocular examination, we can see that there is this peripheral corneal opacification, and central also is more, central is less involved compared to the periphery, and we cannot differentiate where the limbus is. More of a peripheral sclerocornea, one can say, with very, very small hypotenuse eyes. Again here, when we look at the UBM, we can see that there is presence of this lens which is stuck on the endothelium along with the iris. And the moment we see this, we think that, okay, could it be type 2 Peters anomaly or Peters plus, because the child is having systemic syndrome as well. Then again, this child became a candidate for further evaluation. So on getting a genetics test, we found these 2 genes. One is the CREP gene, which was more of a missense mutation, and Menke-Hennekam syndrome, which has facial dysmorphism, feeding difficulties, microphthalmos, deafness, which our child also subsequently had, and all these features that our child had fit perfectly into this syndrome. While you must differentiate this from Robinson-Tivy syndrome, which is on the same gene, mutation on the same gene, almost on the same axon or at times, but there is loss of function mutation compared to a missense mutation. We did advise a parental Sanger sequencing. Along with that, it is mentioned that this syndrome you must do genetic counseling, very good genetic counseling, because some of these children can have failure to thrive because of the feeding difficulties. Some may need gastrostomy as well. So you must do a good genetic counseling. Like in our case we did, but the parents were quite skeptical about getting it further. That is one of the obstacles which we all face. Another child, again, having the central corneal opacity bilateral with iridocorneal adhesions with excavation of the stroma, who ultimately had this GDF3 and oval 2 mutation, again, not commonly seen with Peters anomaly again. This child otherwise did well by bilateral SEPA with optoclaridectomy. So we advise further Sanger sequencing of the parents, which showed a GDF3 mutation in the mother, and that leaves us with the OVAL2 mutation. Again, not associated with fetus anomaly, which is more commonly seen with endothelial dystrophies like PPMD3 or maybe CHED. So again, these were the 3 cases where phenotypically they were like pointing towards fetus plus, but genotypically they are showing some other mutations. Maybe Professor Ken can help me out in the end. So this is another child who presented to us after open globe injury repair, because he was he had a trivial trauma while he was writing with and the eraser hit his eye, and he had OGI. After OGI repair, he was referred to us for aphakia management. Here we can see that there is presence of bilateral bluish sclera, and ocular, like the cornea appears relatively clear. And on doing a Schemfleck imaging, you can see there is very thin corneas, that's like diffusely thin corneas in both his eyes. And the primary surgeon did not realize while doing a suturing, she did not mention any difficulty in suturing. While looking at this, this child definitely had this thinning. And we, ultimately we did do a proper workup of this child. But I want to show that 6 months later, this child had opposite eye injury. You can see that there's iridocorneal adhesions are here with the perforation, and we did a patch graft, and luckily we got a small tissue which we could send for histopathological examination, where we can see the lamellae are very loosely arranged in the eye with various stains, and his genetics, which was done earlier 6 months prior, was positive for a ZNF469 mutation, which is positive for a brittle cornea syndrome type 1, while the type 2 shows this PRDM5 mutation, both of which are part of this Ehlers-Danlos syndrome spectrum. So we did a screening, family screening, where they said that the elder brother has been on treatment for primary congenital glaucoma for the past, from the time of his birth, because the moment he was taken for examination, parents felt that his eyes looked quite prominent, so he was examined at when he was an infant, and he was diagnosed to have primary congenital glaucoma. And his old records showed that in all the readings and the EUS that he underwent elsewhere, his pressures were like 8 or 6, not more than that. And they had also mentioned that his optic disc is fine, but he was still kept on a thing, and he was diagnosed to be having keratoglobus. So when we knew that he also has the same disease, because he has bilateral bluish sclera and a very steep cornea. Here on the AIOS2025, you can see that the cornea is very steep and the deep anterior chamber depth. And then both the siblings did not have posterior steepening like you see in keratoconus, even though keratoconus can also be associated with brittle cornea. So we did a Sanger sequencing, which had the same mutation as ZNF469 like his younger brother. And another feature that we found here is which the pediatrician also pointed out, that the father as well as the siblings, they had dolichocephaly, which was another feature, but it's a very uncommon feature. So, okay, there is still some time. I just want to show that when you see a child of corneal opacity, always do a thorough phenotyping and a deep phenotyping of the child, and do not miss the posterior segment, because this child presented with this thick corneas and bilateral opacities, but then also had some ultrasound features, and then the child was finally diagnosed to have FEVR or LRP5 mutation positivity, which has this exudative RD component. So just the spectrum of cases I wanted to discuss, and I'm happy to take comments and Professor Ken's comments as well. Thank you.
Yeah, why not?
I'd like to acknowledge my
those are very
pediatric center, APC
very interesting cases, and we'd like to have expert comments from Dr. Ken Nischal.
I think you demonstrate very nicely that we really shouldn't be. Oh, look at that big head there. Let me stand out the way. We really shouldn't be using the term Peters anomaly, because you're trying to find a genetic cause for a sign. It's like saying you're trying to find a genetic cause for a cough. So I think your deep phenotyping was very, very helpful. In my experience, Peters plus children always, the true Peters plus syndrome, due to a mutation in beta 3 GLTL, they always have a cleft palate. I've never seen
Okay.
one without a cleft palate. I don't know if anybody else has. They always have a cleft palate. So I wouldn't call it Peters Plus until you see the cleft palate, the short arms, and they have this sort of rather very big forehead. Now there was a case that you showed where you had a change in a gene that gives you Fanconi anemia.
Yes, yes.
I can tell you categorically that that was the cause. And you need to go back and you need that child looked at with a pediatrician because they get malignancies.
Yes.
And we published a paper on Fanconi anemia, and what your clinical phenotype was identical to the paper that we published.
Okay.
You thought it was another syndrome, but
Yes.
that was Fanconi anemia.
All right.
So you have to go back and get that child urgently looked at by a pediatrician.
Yeah, he is at a follow-up.
Yeah,
Yes.
but yeah, great cases. And I think that what you demonstrated is that without without imaging, you really don't know what you're looking at.
Yes.
And I think the other thing is there was a case that you showed, the LRP5 case, the last one. So we published with, oh my God, Shulja Tibrewal. We put Peters anomaly masquerade. And we've both had two cases where it looked like Peters anomaly, but the lens was pushed forward either because of an exudative detachment or familial exudative retinopathy. So what you're showing again is that the opacity in the cornea is only a sign.
Yep.
And it could be caused by different things.
Yes.
And that case shows very nicely that it could be the retina.
Yeah.
Well
Thank
done.
you. Thank you, Dr. Ken.
Thank you for those insights. And that's how molecular diagnosis is helping us. It's just not what we are just seeing. Obviously, identifying the cause as well, what's important. So, do you want to have
Can I make a comment?
yeah, please. Yeah, yeah.
I think in optic atrophy, the most important thing is once you make the molecular diagnosis, it helps you modify behavior. I mean, it's really important for idibanone or coenzyme Q, but you now have to say to them, stay away from secondary smoking, don't drink alcohol, because we don't know what the trigger can be, you know, and if you put oxidative stress, you know, don't do recreational drugs, because they could lose their vision completely. So I think that's, for me, that's the most important thing, because the parents have something to hold on to, and so does the child, though it's very difficult, you know, teenagers and all the peer pressure they have.
That's very important. I mean, because psychologically they would be quite upset as they grow, the children, and can get into any of these smoking or alcohol, and they have to be told that yes, it's going to be worse if you get into these. So that's an important point. Thank you.
So is it you advocate whole exome, or it's a targeted exome sequencing? What is the take-home thing which you would like to tell us as clinicians?
So part of it is down to your clinical suspicion. So you don't have to test for all genes necessarily if you really think that it's a particular one. Say if it's aniridia, you're not going to do whole genome. You're going to go straight for, well, if it's a child, you're going to do an array to look for WT1 PAC6. But if not, you're going to just look at PAC6 and you've got 98% chance. But, you know, just be aware that there are overlapping phenotypes, pseudophenotypes. So, you know, spot diagnosis, you can't always do that. So you just have to be careful. But I totally agree with Ken's point. So we should slightly start moving away from retinitis pigmentosa, Peters anomaly, you know, because those are kind of general descriptive terms. We should kind of start moving towards a gene-based classification for these conditions, because then we can absolutely then give proper guidance. May not have a treatment, but we can absolutely guide lifestyle changes, dietary requirements, etc., based on the gene, rather than a kind of a blanket, oh, you mustn't do this or you should do this. So down to it, you would apply a targeted panel if you're not sure. If you know the gene, you can go for that. Again, it's about cost and what you can do and what you can't do. But even when we do whole genome, we don't just do a whole genome. We would do a whole genome and then only apply a targeted panel depending on what we're looking for. Sometimes it's also beneficial to apply 2 panels. So if a child has a learning difficulty and, for example, cataract, you could do 2 just to check. And then remember as well, if you have children with developmental delay and learning difficulties, you may want to start with an array first because that's cheaper and quicker before going into exome as well. So.